Welcome to this tutorial on the Cognitive Assessment and Care Plan, CACP. The information given in this training is correct as of the date of publication. The most current information contained in this presentation can be found on the Noridian Medicare website and the CMS website at the links listed on the slide. If a physician or other clinician eligible to bill an evaluation and management or annual wellness visit finds a patient showing signs of cognitive impairment during the AWV or other E&M visit, Medicare covers a separate visit to thoroughly assess the patient's cognitive function and develop a care plan. This is CPT 99483. The service is able to be performed via telehealth. These CACP services are designed to improve detection and diagnosis for beneficiaries with Alzheimer's disease and related dementias, or ADRD. Another feature for this visit is care planning and coordination. It provides reimbursement to eligible billing practitioners, a comprehensive clinical visit that results in a written care plan. This additional evaluation is necessary to diagnose a person with dementia, such as Alzheimer's, and to identify treatable causes or co-occurring conditions such as depression or anxiety. Cognitive Assessment and Care Planning, or CACP, requires a multidimensional assessment by an independent historian. An independent historian can be an adult child, parent, spouse, guardian, or other individual who provides patient history when a patient isn't able to provide complete or reliable medical history. This assessment includes cognition, function and safety, neuropsychiatric and behavioral evaluation, reviewing all medications, and assessment of caregiver needs. Cognitive assessment and care plan services are provided when patient who exhibits signs and/or symptoms of cognitive impairment is required to establish or confirm a diagnosis, etiology, and severity. Do not report cognitive assessment and care plan services if any of the required elements are not performed or are deemed unnecessary for the patient's condition. For these services, see the appropriate evaluation and management E&M code. Any practitioner eligible to report E&M services can provide CACP. Eligible providers include physicians, MD and DO, nurse practitioners, clinical nurse specialists, and physician assistants. Many of the required assessment elements can be completed by appropriately trained clinical team members. You can perform the assessment at any of these locations: office or outpatient setting, private residence or home, care facility like a skilled nursing facility, rest home, and also via telehealth. You must have an independent historian present and documented in the record. You will typically spend 60 minutes face-to-face with the patient and independent historian. Cognition-focused evaluation includes a pertinent history and exam, conduct a functional assessment of basic and instrumental activities of daily living, including decision-making capacity, which must be present in the record, use standardized instruments for staging of dementia like the Functional Assessment Staging Test, FAST, and Clinical Dementia Rating, CDR, medication reconciliation, and review for high-risk medications. Continuing on with the cognitive assessment requirements. You must have an evaluation for neuropsychiatric and behavioral symptoms, including depression and anxiety, including use of standardized instruments. evaluation of safety at home, including vehicle operation, and this must be included in the medical record. Identify social supports, including how much caregivers know and are willing to provide. Caregivers should be identified within the record. Address advanced care planning and any palliative care needs. Creation of a written care plan, which includes initial plans to address any neuropsychiatric symptoms, neurocognitive symptoms, functional limitations, and referral to community resources as needed. This care plan must be shared with the patient and/or caregiver at the time of initial education and support and documented in the record. Care plans should be revised at intervals and whenever there is a change in the patient's clinical or caregiving status. You will use the information gathered during the assessment to help create the written care plan. This will include your initial plan to address neuropsychiatric and neurocognitive symptoms, any noted functional limitations, and referrals that may be needed to community resources. The written plan must be discussed with and given to the patient and/or family or caregiver. This face-to-face conversation must be documented in the clinical note for all encounters reported using 99483. The care plan must be filed in the patient's medical record where it can be easily retrieved and updated. It is recommended to share this written care plan with any other providers involved with beneficiaries' care. This slide provides you with the short description, the CPT or HCPCS code, and some general information. Your documentation should include any cognitive relevant history. This should include any factors that could be contributing to cognitive impairment, such as psychoactive medications, chronic pain syndromes, infection, depression, and other brain diseases. The documentation of medical decision-making should include current and likely progression of the patient's disease, the need for referrals for rehabilitative, social, legal, financial, or community services, including meal and/or transportation and other personal assistive services. Identification of patients eligible for this service for whom no diagnosis has yet been firmly established will require excellent documentation that confirms the presence of cognitive impairment and provides the narrative history that spurred suspicion for a potential cognitive impairment diagnosis on the part of the practitioner. Standardized validated tools should be used and are required for some elements. For any scoring tool assessment performed, the full instrument raw scoring and results must be available for Medicare Administrative Contractor review if requested. Documentation of cognitive assessment must be present within the medical record. Decision-making capacity of the patient must be documented within the medical record. The practitioner should at least note if the patient is able to make their own decisions or is not able to make their own decisions, or that decision-making capacity is uncertain and will require further evaluation. Final care planning must result in identification of who will be making decisions in the event that the patient cannot. Documentation demonstrating full reconciliation of medications must be present. Many 99483 elements overlap with other CPT codes. CMS provides specific guidelines on which CPT codes cannot be reported together with CPT 99483 on the same date of service. They include a lot of mental health codes, new E&Ms, advanced care planning, etc. When billing two or more codes in Medicare On the same day, it's always a good idea to check the NCCI website first to make sure they are not bundled. More can be found at this link. In April of 2022, CMS issued a National Coverage Decision, NCD, that covers monoclonal antibodies directed against amyloid for the treatment of Alzheimer's disease approved by the FDA. As of July 6, 2023, Medicare more broadly covers Leqembi and now Kisunla under this NCD. You can also find detailed information regarding the monoclonal studies on Noridian's JE or JF web pages. Just go to the Browse by Topic and click on Mental Health. Then find the link for Cognitive Assessment and Care Plan. I highlighted the CMS web pages where you can find this information. On the left screenshot, I also highlighted the NCD number to look up, if that may be easier for you. Here's the resources to support this presentation. The toolkit from the Alzheimer's organization has so many additional details to assist. Thank you for taking the time to listen to our tutorial. Continue your learning experience by referring to additional recordings available on the Noridian website or YouTube channel.